it's really around molecular testing, and so I'd love to hear each of your institutional approaches. One is around liquid versus tissue, or what's your generalized approach to molecular testing, and two is, are you having any issues with insurance reimbursement, patient cost, financial toxicity related to that molecular testing? And so if it's okay, maybe I'll start with Dr. Desai, and I'd love to hear then from Dr. Kim.
Yeah, I think this is obviously a very important question. I mean, obviously biomarker testing is now standard of care, as highlighted by Dr. Kim as well. I think for the tissue versus liquid approach, I will say historically, obviously before liquid biopsy, good data for liquid biopsy testing started to come out, historically our approach has always been like tissue NGS as standard of care, and it's still the gold standard, considered. But I think, ISLC and other organizations, and I think there's emerging data of this so-called complementary approach, where you would probably send NGS testing both on tissue as well as with the liquid biopsy. There have been instances where you can identify, mutation, a targetable mutation on one versus the other. And so I think, using this more as a complementary approach, I think makes sense. And that's something that I'm trying to incorporate into my practice, over the last few months or a year or so. I think in terms of institutional, I would say like most people, when we have a, biopsy where we have enough tissue, tissue NGS, like I said, is still the gold standard. I think the practice varies per providers in terms of whether they send out upfront liquid NGS testing or just send it out, when you have progression after the frontline therapy, and then you're trying to identify these mechanisms of resistance. With regards to the second question, I think that's a question I personally have as well. I try to ask my patients if there were any copays or anything that, was sent to them by the insurance or the vendor in terms of the cost of NGS testing. I think there's really a paucity of data with regards to that. I think that's an interest area actually for me to identify what kind of financial toxicity happens when we're talking with the biomarker testing. I do know that there was a national coverage determination for Medicare that came out, I think now a couple of years ago. So I think that has made things easier. There's data to show that there is actually increased NGS testing since then, but I think it's still not complete, and a lot of work needs to be done in this space.
Yeah, I agree with Dr. Desai. And in terms of my practice, if I have a patient with a newly diagnosed stage 4 non-small cell lung cancer, I tend to use both liquid and then tissue NGS. I know that there's a lot of controversies about how to sequence, or should we sequence, or do you do like parallel testing at the same time? I think the answer has not been fully answered yet, but at least in my practice, I like to send liquid to get the results pretty quickly in about 6 to 7 days. Because tissue NGS is probably more comprehensive, incorporating RNA sequencing and things like that, and you can get additional information that way. But then there's an issue of turnaround time. It's not, we hope to get the results relatively quickly, but then sometimes there's various issues that lead to a delay of getting the results. And so in my practice, I use both liquid and tissue NGS.